Change on addressing ICU delirium and why sleep is important. This presentation was developed to examine how delirium in the intensive care unit setting is affected by sleep. Much focus is placed on treating patients after they develop delirium versus preventing and early detection. This presentation will examine how incorporating sleep hygiene techniques can decrease the occurrences of delirium. So my name is Denitra Nash, and I currently reside in Richmond, Virginia. I've been a nurse now for 7 years, and I've spent all 7 of those years working in a critical care setting. For the last 3 years, I've worked in a surgical ICU where our main focus has been on cardiac surgery. Delirium has a rapid onset, manifesting within hours to days. Delirium in the intensive care unit setting affects 60 to 80% of ventilated patients and 20 to 50% of all other patients. Research has shown that sleep deprivation has been linked to delirium in the ICU setting. My interest in ICU delirium stems from personally seeing several cases over the years, the fact that my place of employment does not have a prevention protocol, and the way that different providers go about treating delirium. So delirium is a serious disturbance in mental awareness resulting in confused thinking and possible hallucinations. The facts are, lack of sleep is a key component as to why many patients develop delirium. The development of delirium in the ICU patients is associated with various consequences ranging from prolonged hospital stay to high mortality rates. Statistics support why delirium should be taken seriously and why evidence-based interventions are needed to reduce its occurrences. National statistics show that the main cause of reduced sleep in hospitals is clinical care intervention. This fact is a cause of concern because studies have shown that a lack of sleep can cause patients to experience delirium. Additionally, ICU patients are more likely to develop delirium due to severely disturbed sleep at a rate of 44 to 87% when compared to patients within the hospital in other units. Hospital Corporation of America is a large healthcare system here in Virginia. The organization's largest hospital in Virginia is Chippenham Hospital. Prolonged hospital stays due to a patient developing delirium, sleep disorder, or other health problems result in higher healthcare fees. Chippenham Hospital, like I said, is a HCA hospital in Virginia, charges $4,725 per ICU day. So you can imagine that how quickly the fees can add up if a patient has had their initial diagnosis resolved but then developed delirium and have to stay additional days in the hospital. You can see how those fees can quickly rack up. The organization statistics shows how additional days a patient spends in the hospital can significantly impact healthcare costs. In addition, the patient, their family, and the healthcare system and society are all impacted by delirium. The patient is subject to spending extra days in the hospital that increases healthcare costs. The patient is also at risk for higher mortality rate and significant long-term cognitive decline. Many family members have reported that they have anxiety associated with their loved ones being in the hospital because they're concerned. 45% of family members report poor sleeping habits due to being concerned about their loved one. The healthcare system spends thousands of dollars associated with prolonged hospital stays. Society is also impacted by having more cases of cardiovascular morbidity and diabetes, which is linked to patients developing delirium. Delirium also impacts quality of life. Sleep disturbances are linked to decrease in quality of life for many patients due to health consequences associated. Delirium presents as a safety issue as it is overlooked in patients who have been on antipsychotics or sedatives. Nurses may not connect that lack of sleep that the lack of sleep for the patient may present complications. There are legal and ethical issues regarding physical restraints associated with delirium. Physical restraints may be used to reduce the risk of injury to patients who are delirious. However, physical restraints may also worsen the condition of delirium and cause agitation. In terms of costs, over a 30-day ICU time period, the incremental cost of persistent daily delirium is significantly higher and increases services and costs about $18,000 per additional stay for the patient. So key scientific underpinnings. In the hospital setting, sleep disturbances can lead to sleep deprivation, delirium, ICU patient, and sleep disorders such as insomnia. The effects of chronic sleep disturbances are associated with serious potential problems such as cardiovascular morbidity, obesity, impairment of immunity, depression, and diabetes. These scientific underpinnings are all important as they negatively impact patient health outcomes. Each underpinning could potentially cause a prolonged or frequent hospital stays, increase health care and hospital costs, and impact the patient's lifespan. So my PCOT question for the project change is, in ICU patients who develop delirium, how does promoting sleep hygiene compared to daily unit activities without implementation of sleep hygiene affect decreased occurrences of delirium in ICU patients within a 6-week period? So to begin my project change, I did a literature search strategy. I used several different databases to gather data and research on my project. The keywords that I used were sleep, hygiene, and ICU, and delirium. In my inclusion criteria, the articles and research needed to be less than 5 years old, in English, ICU patients, and in particular, I wanted academic journals. My exclusion criteria, I did not want anything that pertained to pediatric patients or anything that provided information or data on patients that were in non-ICU settings or were not ICU patients. So after putting in my criteria and gathering my data, 16 of the 38 articles were related to my PCOT question. After excluding articles that happened to slide through the cracks that were based in a pediatric ICU and removing duplicate articles, 5 studies emerged from the literature review. So my evidence table is also attached here with this PowerPoint. Evidence synthesis. For this synthesis, literature was reviewed to answer if sleep hygiene interventions decreased occurrences of delirium in ICU patients when compared to daily unit activities without sleep hygiene. The trend themes among all studies and summaries was that sleep hygiene interventions implemented within a protocol decreased risk and development of delirium. Blocking time from midnight to 4 in the morning to create a rest period, and those time frames are also flexible, was shown to be beneficial within 2 of the studies. For the other 3 studies, sleep hygiene interventions such as using earplugs and an eye mask, or just one or the other, exclusively promoted sleep and decreased the number of awakenings throughout the night. Sleep disturbances are modifiable factors that decrease the risk of delirium. All literature implemented a sleep promotion protocol. The protocol consisted of various sleep hygiene interventions, including providing earplugs, eye masks, and designating blocks of time to promote rest and limiting patient care activities during that time frame. So what are the practice recommendations? After reviewing all the literature, it is appropriate to conclude that sleep hygiene interventions have a positive impact on ICU delirium. Implementing interventions with a sleep protocol improves the patient's quality of sleep while decreasing chances of developing delirium. All studies utilized a sleep hygiene technique. However, the technique was not consistent across the literature. The main thing was to promote sleep and make sure that patients were getting adequate rest throughout the night. Some studies implemented using earplugs and eye masks or creating a sleep environment, while others created a time block to limit distractions and non-emergent care activities. Some patients could not tolerate wearing earplugs and felt claustrophobic when using the eye mask, which interfered with the data collected. So overall, the sleep hygiene interventions decrease occurrences of delirium. Using the Johns Hopkins quality grade, it's a level B, and the SORT measurement is also a level B as well. The main outcome of the evidence-based practice change is to decrease the occurrences of ICU delirium. The goal will be accomplished by collecting data on ICU patients who develop delirium to create outcome measure. The data will consist of noting when the patient was admitted to the ICU, their length of stay, the onset of delirium. Baseline data would be noted as to how many occurrences of delirium will be prior to the practice change and how many occur after the practice change is implemented. The overall goal is to decrease the occurrences by 50% in a 6-week time frame. The main metric used will be the CAM ICU algorithm to assess the development of delirium. As you can see, the confusion assessment method for ICU patients has been provided here on this slide. So basically, it would assess each patient every day to determine, it's basically an early detection method to determine if patients have developed delirium or are in the process of developing delirium. So the action plan, we would use the Connor 8-step to help put the action plan and timeline in order. We would start with urgency, which would be planning the project and gathering the data and communicating why the practice change is necessary. This would be the responsibility of the project manager, and this would take roughly about a week or two to complete. The next step would be the team selection. This will be identifying stakeholders and team members who are willing to commit to the project change. This would also be the responsibility of the project manager. The strategic vision would create the timeline and vision for the project, meet with the team members to communicate the goals of the project. This would involve the project manager, team members, and stakeholders. Roughly each task will take somewhere between 2 weeks to a month to complete. Enlist volunteers. This will entail meeting with all team members, stakeholders, and brainstorming on ideas and communicating on what interventions need to be used and then allow for them to give feedback on how they feel about the project. We would then move into removing any barriers. This will be done by communicating the vision, getting the team to buy in, and identifying any obstacles that may be presented throughout the project. We would then create a short-term win, which would acknowledge staff, give them positive feedback, acknowledge communication, commitment to change. So this would occur once the project is implemented, roughly 2 to 3 weeks into the implementation of the project, just to keep the team on board and on the right trail to successfully completing the project. We will then build onto the change. This will allow for any new barriers that weren't foreseen to be addressed and to accept feedback from the team. And then we would create the change. This would entail evaluation of the outcomes, again, feedback from the team, stakeholders, patients, and any changes that may need to be implemented to the project.